We would like to acknowledge the traditional custodians of the land that this podcast was recorded on, the Wurundjeri people of the Kulin Nation, and pay our respects to elders past and present. First, a warning. This episode mentions medical trauma, themes of mental ill health, and transphobia. Listener discretion is advised.
There's grief, not just about the diagnosis itself, but what that might mean for your future, your independence, your sense of self.
The fear of all of this is that nobody cares.
So we see that friendships can slowly fade. I think this is the quiet heartbreak that can happen for people.
It helped me in more ways than I could ever imagine, being able to hear other people's stories and then also being able to say the words out loud.
This is not just frustration. It can lead to trauma. Medical gaslighting can lead to trauma, just like other forms of trauma.
Welcome back to Beyond Hysterical. I'm going to start this final full-length episode by sharing something really personal, and it's something I haven't spoken about before. Over the last 4 years, in between surgery number 1 and surgery number 16 for my chronic condition, I've developed a fully fledged phobia of hospitals. Let me paint a picture of how this fear crept in. Scene number 1. I woke up from one operation a couple of years ago to find out the surgery had been botched and I'd need a do-over. Nobody could tell me if I'd be waiting months, weeks, or just days or a couple of hours for my corrective surgery. The surgeon was too busy to talk. Scene number 2. The anaesthetist had left the hospital without prescribing any pain medication. He had other patients and apparently he'd just forgotten. I was in awful pain and nobody could tell me who else could prescribe the medicine or how long I'd have to wait. Scene number 3. I had a panic attack in the recovery ward. And when I asked a nurse, mid-meltdown, for my phone to call my husband, she said, "You can have it when you calm down." I wasn't hysterical. I was terrified and sore, and I was being treated like a security risk. Over time, these small moments piled up until they felt too heavy to bear. I developed an aversion to hospitals. I found myself bursting into tears in the ER, spontaneously weeping at acupuncture appointments when the tiny needles poking my wrists and arms reminded me of the hours nurses have spent trying and failing to insert cannulas into my veins. The cruel irony here, my disease doesn't care that I hate hospitals. I still have to keep going back to them, over and over again. I'm sharing all of this because my experience isn't uncommon. Chronic illness can do a number on your mental health, and being gaslit, dismissed, or treated like a drama queen makes it so much worse. So today, in our 5th and final full-length episode, we're exploring the psychological toll of medical misogyny, what helps, and how mental health care could use a shake-up to better support women and gender-diverse people in the medical system.
They told us, sweetheart, it's all in your head. Just a womb on the move, the man once said. Time moved on, but a shadow remained. Our pain ignored, she's emotional again. Brushed off, blamed, in creeps self-doubt.
Chronic illness diagnosis can be completely life-changing. And that's not just physically, but it's emotionally and psychologically. I think that the emotional impact is rarely acknowledged.
Meet Siona Ilalio. She's a psychologist at Livology in Melbourne, a clinic that works with people with chronic health conditions and disabilities. Siona also hosts the But You Look So Good podcast, where she and her co-host Sally Shaw shine a light on the realities of living with chronic health conditions. They both have lived experience. Siona, thanks for joining us today. I wanted to start by asking, to what extent can living with a chronic health condition and all the challenges that entails impact someone's mental health?
So first and foremost, there's grief, not just about the diagnosis itself, but what that might mean for your future, your independence, your sense of self. So it can bring huge shifts in identity, especially if you're not able to do the things that you once could or that once defined you. So life can suddenly feel really unfamiliar. I often hear clients say it feels like their life's been tipped upside down or turned on its head.
There are high rates of anxiety and depression among people who live with chronic health conditions. And Siona says that makes sense, given what they go through.
It's that full spectrum of emotions that we can feel: frustration, anger, shame, guilt, loneliness, It's really, I would say it's a real mixed bag and it can change day to day. These are very normal human responses, not signs of weakness, but just very normal your human reactions when you're living in a body that isn't doing what you're asking it to.
A Nielsen survey in March 2025 found that women with so-called women's conditions, like endometriosis, gynecological cancers or birth trauma, have really high rates of psychological distress. 45% of this group reported severe mental distress, which is a lot higher than women in the general population. For that group, it's about a quarter. I asked Siona Ilalior about the psychological impact of not being taken seriously when you seek help for a health condition.
Being repeatedly dismissed, not believed, or told, a very common one, it's all in your head, profoundly distressing, or maybe destabilising is a better word, profoundly destabilising, I think. And over time, this can contribute to what we now recognise as medical trauma, what we're talking about, even medical PTSD in some more severe cases.
Here's how this works.
When someone seeks help and it's met with disbelief, when it's minimised, or blame, it can absolutely erode their trust in healthcare providers. It can erode their trust in themselves and they begin to doubt their own perception of pain or symptoms, which can lead, I've seen it lead so many times to anxiety, hypervigilance, shame. She's such a killer, shame shows up, or confusion.
That erosion of trust in yourself is a key point. In fact, UTS researcher Jane Hutchins, from episode 2, looked at women with heart disease during pregnancy and after. She found that some of those women blamed themselves when they had a bad experience. They felt they'd done the wrong thing by not advocating for themselves, which of course they hadn't because it was never their fault. Being constantly dismissed and disbelieved also led women to question their own reality, to wonder if they were just remembering things wrong. The result was more fear of uncertainty, fear of death, and a devastating hit to their mental health, their self-confidence, and their self-belief. Siona Ilalior explains how this looks over time.
I mean, over the years, I've heard countless stories of clients who have experienced medical gaslighting on a really long journey to a diagnosis, and it leads to impacts like delayed help seeking. So even when something else shows up, even in emergencies, they may delay getting help. Heightened anxiety, and that can be around medical appointments, putting off getting test results, feelings of helplessness, powerlessness.
And there's another burden for many of us to bear. Anger. So much anger.
I often see, which is an interesting one, a lot of anger or grief, resentment over the lost years without support, especially when people do find good support. They look back and think, they're so angry about going sometimes a decade, which is awful, or decades, without being believed.
Chronic pain can also be a major trigger for anger. And then there's the way chronic illness can alter family roles and dynamics, which can lead to frustration and anger for everyone within the family unit.
There's such a big emotional toll of carrying your own health story, I guess, alone for so long, and having to prove your pain or explain yourself over and over.
And then there's another biggie. That feeling that others don't quite get it. A sense that friends are falling away the longer you're unwell. The feeling of being truly alone in it all.
People with chronic health conditions do report high levels of isolation and loneliness. And, it's such a common presentation that we see clinically. I think there's so many reasons why. One of the ones that I talk about a lot is that chronic health conditions can be so uncomfortable for others to witness, but also talk about. So friends and family often don't know what to say, or they worry they'll say the wrong thing, which is very common, or they feel unsure about how to support someone. And unfortunately, this leads to silence, inaction, sort of withdrawal, rather than what we really hope, which is connection. So we see that friendships can slowly fade. I think this is the quiet heartbreak that can happen for people. The invitations stop coming. Over time, people can feel forgotten or excluded from the world that they used to be a part of.
And on top of this, Siona points out that many chronic symptoms are invisible.
So there's fatigue and pain and brain fog, and that becomes hard for people to empathise or fully understand what someone is going through. And if you're experiencing fatigue or pain or mobility challenges, cognitive difficulties even, it can make even small interactions feel exhausting. And as a result of that, it can just naturally reduce someone's social interactions. And the important part is that's not because they want to, it just becomes really hard to do that.
Reduced social interactions is not just being bummed that you missed a good night out. It's a crushing feeling that you're getting further away from your friends and from yourself.
So when you feel disconnected or misunderstood, it makes sense that can feel anxiety, depression, just a deep sense of disconnection from your former identity, I guess is probably the way to put it.
This stuff isn't just hard to manage, it can actually be traumatic.
There was some recent research from Cambridge University, which has really just highlighted the profound psychological effects of medical gaslighting, which we know now, and that's particularly for individuals with chronic health conditions. So we know that this is happening frequently. We know how important it is to actually name. I'm very passionate about this name, that this is not just frustration. It can lead to trauma. Medical gaslighting can lead to trauma, just like other forms of trauma. And it really does deserve recognition and support and recovery.
But when we talk about healthcare experiences causing trauma, what do we actually mean? A brief explainer here, because medical trauma and medical PTSD are sometimes used interchangeably, but there is a difference.
Medical trauma refers to the emotional and psychological distress that arises from a medical experience. Medical trauma might stem from, there's so many things, but it could be a frightening or a painful procedure that's unexpected. It can be a sudden diagnosis, like a life-altering diagnosis. It's traumatic to be fine one day and then not the next to receive a diagnosis. There's ongoing mismanagement or dismissal of symptoms. Chronic mismanagement can certainly lead to medical trauma. Loss of autonomy or control over your decisions is another big one. And just generally feeling ignored, misunderstood, or disbelieved. So even if something goes well, if a procedure goes well, it's the way the care is delivered. So especially when it's invalidated or you've been dismissed or it's been rushed or it's invasive, that can be medical trauma and that can leave quite a deep emotional imprint.
And then on the more severe end of the medical trauma spectrum, we have medical PTSD, post-traumatic stress disorder, which is a diagnosable mental health condition. So all medical trauma takes an emotional toll, but not all medical trauma leads to actual medical PTSD.
That is when somebody develops post-traumatic stress symptoms following a medical event. And so when we think about PTSD, the symptoms include flashbacks or nightmares, so really significant about the events. And a lot of people can avoid hospitals, doctors, or even thinking about medical care. They can feel anxious, panicked, or unsafe, difficulty trusting healthcare professionals, hypervigilant, or feeling constantly on edge. So these are significant symptoms that can affect someone's healthcare journey.
Thanks, Siona, for explaining that. I have to be honest, at this point of the interview, I'm getting goosebumps because this all sounds incredibly familiar to me. But there's some good news, because she says both medical trauma and PTSD are treatable.
But there's hope that with the right support, that you can be validated, whether with a mental health professional or from a peer group, or just finally being believed, that people can start to reclaim a sense of agency and safety and I think self-trust.
If it's a route you're thinking of going down, there are several different types of trauma-informed therapy to consider.
If we think in the psychological world, the sort of trauma-informed therapy, there's EMDR, which is eye movement desensitization and reprocessing. It's quite a mouthful, but it's a pretty well-known therapy. There's lots of robust research around EMDR being very beneficial for people who have PTSD. There's other things like somatic therapy, trauma-focused CBT.
You can also just unpack your thoughts and feelings related to the trauma with a psychologist, but you'll need to ideally find someone who understands medical trauma. Siona Ilalio also suggests looking into something called medical advocacy.
So, working with either a psychologist or there's actually medical advocacy coaching. There's people who can help in this space and they can help you to, be more prepared and informed. So with the aim of reducing future trauma.
And she adds, and this is really important, you don't need a formal PTSD diagnosis to get help.
You can have medical trauma, you can have things showing up, and you can seek help for that. And that's really important.
At this point, I want to hear from Erin.
So a licensed therapist is another great resource for support.
You might remember Erin, who lives with Hashimoto's disease, which took at least 6 doctors to diagnose. And before she got that diagnosis, she tragically lost her son. You can hear her full story on episode 2. Erin tells me she's a big advocate for therapy.
When I could get into a licensed therapist, that was huge. I 100% recommend that to anyone going through anything that they're facing a struggle with, because being able to just vent and let somebody that doesn't have any skin in the game take on that burden of all of your struggles and then being able to leave it with them is so powerful.
So therapy can be really useful, but there's just one question, the $300 question. How are we all meant to afford therapy when psychology consults cost about $318 each? That's the suggested fee by the Australian Psychological Society, and it's out of reach for many Australians, especially during a cost of living crisis. MJ O'Neill, from episode 4, managed to get a formal diagnosis for her ADHD, although it did take 18 months. And she says cost is a major issue.
If I had to brave that process now, I don't know if I would have made it to the end of it. And it's just because with the resources that I currently have, I don't know if I could afford it. I don't know if I could do it.
Subsidised psychology sessions are available under Medicare for people who get a mental health care plan or a chronic health management plan. But those rebates usually only cover a portion of the appointment cost. And there's also a cap on how many of these subsidised sessions you can get each year. That's 10 for mental health care plans or 5 under chronic health management plans.
Yeah, it's great that Medicare has rebates, but every specialist I go to, I have to pay a gap. My psychologist has gone probably about a month without me paying her, just because I've said I need to pay for other things now.
Even with rebates, therapy can still be out of reach.
And so it's this thing of if you ask how affordable it is, it's a very relative thing. But if you ask, is it affordable, the answer is no. And I'm very fortunate, and I'm barely affording it.
So for those worried about the cost of mental health care, what are the options? Your first step, if you want to see a psychologist and access Medicare rebates, is to see your GP. They can create a mental health care plan, which is the one that gives you access to up to 10 rebated sessions per calendar year. Here's Siona Ilalior again.
And how much you get back is very dependent on psychologists, but it is somewhere between $97 and $140 per session that you receive back. But there is a gap fee and there's out-of-pocket costs. So it depends, but your GP might know of some professionals who do offer reduced fees. So it's absolutely worth asking.
What about bulk billing psychologists? Siona says they're rare, but they do exist.
I would say there's more that offer sort of sliding scale options depending on your situation. Again, it's really worth asking. And if you have private health insurance, that can help cover part of the cost. It's unlikely to cover everything.
You could also consider the EAP, Employment Assistance Programs.
Lots of workplaces offer free counselling sessions through the EAP. I often think they can be an excellent starting point for support. I've had clients who have accessed EAP for years and they found them incredibly beneficial, the counsellors or psychologists they've seen.
Not everyone knows this, but even though EAP services are offered by workplaces, they actually offer counselling related to all sorts of issues, not just work concerns. And they're confidential, so your boss won't know you've talked to an EAP counsellor. There's also value in informal supports. That might start with your immediate circle, your best friend, your brothers or sisters, your mum. Siona says that even if they don't always know how to show it, the people closest to you usually do want to support you. They just might need a little guidance on exactly how.
And so I like to think about it as the A-team, and that's the people who, family, close friends, partner. It's really helpful, if not crucial, to talk about how you want to be supported and how you'd like to talk about your health. which I know is not always easy, especially when you're navigating, of course, your own adjustment.
Outside of the A team, other patients with similar experiences can also be helpful resources.
And while that doesn't necessarily replace professional help, it's really valuable. So online peer programs or support groups can offer understanding and validation and connection, of course, with people who get it. That said, I think the tone sometimes of those online spaces can be a bit heavy or symptom focused. So again, it's about finding the right one.
The right peer support group can be worth its weight in gold. After my diagnosis, I started attending peer support sessions online through Crohn's and Colitis Australia, and they also have a WhatsApp group that I'm still active in. It's been such a valuable resource and I can't recommend it enough.
When you connect with others who really do get it, the validation, that shared experience, it can be so powerful. It's just being seen and understood, and that absolutely can help reduce feelings of isolation.
Peer support communities have been incredibly helpful to Erin too. After her son died, she created a non-profit and a 5K race in his memory. And Erin says connecting with others through that community face to face has been invaluable.
I think a lot of times nowadays with the internet, we lose that component. It helped me in more ways than I could ever imagine, being able to hear other people's stories, forming these relationships that now have turned into friendships. And then also being able to say the words out loud really just does something of acknowledging it and also kind of putting it out into the world. Sometimes we're told to just be quiet and hold it in. But if you can talk about it, it's so helpful. It really makes a difference.
And here's MJ again. She does go to therapy. It's often unaffordable. The good news, MJ says, is that social connections, tapping into community, is really helpful when it comes to finding support.
It'll be just being able to have a friend that you can go to and be like, this fucking sucks. That is in and of itself a really valuable function for people to have, and one that some people just don't have. It's the only way we manage it is essentially, some of us reach out to the other and we build these little communities, and those communities kind of help each other through it.
But what if you don't have an in-person A-team or an IRL support group like Erin and MJ do? Well, Erin says social media communities can be a helpful place to turn, even if it's just while waiting on more professional services.
Coming from a rural area, the mental health aspect of finding a counselor was very expensive and very hard to get into. So while I was on the wait list for a lot of places, I ended up going on to Facebook and some other social media platforms, and I found a lot of support through just typing in some keywords there, which was great.
One upside of online communities is they're accessible if you live remotely or if you have mobility restrictions. They don't replace medical advice, of course, and sometimes you do need to approach these groups with caution because they can be hotbeds of misinformation. But equally, they can offer a place to ask questions that only people with your same condition or symptoms might really get. Here's Erin again.
I got a lot of, ways to control it, diet help, or questions to ask my providers, or things to do when I had flare-ups. And these were really, really helpful support groups with controlling my symptoms or being able to navigate my healthcare in the future.
So there are some supports out there, but there's also room for improvement. Money is not the only reason women and gender diverse people don't reach out for mental health support. Not everyone can access services that meet their particular needs. Take being trans or gender diverse. Research has shown that more than half of trans people in Australia have avoided seeking healthcare at some point because of past experiences of, or fear of, discrimination. And that study, by the Trans Health Research Team at the University of Melbourne, was only a snapshot of 2 years. So imagine how this affects someone over a lifetime. I asked MJ O'Neill about whether she was surprised to hear that stat.
It doesn't surprise me. I don't think it's a case of having to find the good ones, but having to avoid the bad ones is probably the short one.
MJ lives with a range of chronic illnesses. And when we met her in episode 4, she shared the financial barriers she'd faced when accessing healthcare, including trans healthcare. She says that for many trans people, it's not just cost that makes it difficult. It's finding someone who understands you.
It's like usually there's some people may not have the sort of grace or the vocabulary to navigate it, but they'll do their best. And then every now and then there's someone who has a very specific ideological stance, and that will be a huge barrier because it not only sort of, they won't give you the healthcare you need, but it also makes it much scarier to get healthcare again. And I think they're generally in the minority, but I know that they exist.
This is a nasty domino effect. Bias and discrimination in healthcare can cause trauma, and then if the mental health care you try to access isn't affirming, that trauma can just stack up.
I know a lot of people who just don't trust their GP or don't trust their the specialist, even if the specialist who's providing them trans healthcare, and you know, but they also won't want to go to someone else because it's like the person is providing trans healthcare. You can anticipate how bad it is, and it's sort of a case of better the devil you know. So yeah, I'm not surprised at all.
And MJ says the current political climate in Queensland, where she lives, but also from overseas, including the US, can make the quest for suitable mental health care all the more difficult.
Particularly now, I think there's a lot of work being done to convince trans people that we aren't welcome. I don't think that that work and that campaigning is reflective of the larger population, but it's hard to know that, and it's hard to trust that.
So what can actually help fix the system? Well, better training for healthcare providers to make sure gender-sensitive and trans-sensitive healthcare is widely available is a start. There's also a compelling argument for a government increase of Medicare subsidies for psychology services, increasing the current cap of 10 sessions a year.
The mental health care plan itself doesn't cover enough sessions.
On this point, let's hear from Jacinta Dietrich. We met her in episode 4.
If you can't even do one a month, that's not enough. That's not a year. I see my OT fortnightly, and then I have a psychologist monthly, but when I was struggling the most, I was seeing them both fortnightly kind of thing. And the fact that, you know, someone who needs it as much as me or more would get it significantly less is just astounding and so disappointing to me. I think that, yeah, it at least needs to be 12 sessions.
During COVID, the Morrison coalition government at the time temporarily expanded the yearly cap on sessions from 10 to 20. But at the end of 2022, the Labor Albanese government reverted to 10 sessions. And since then, it's been a hotly debated issue. In a rare moment of unity, the Greens and the Coalition have both said we should expand access to Medicare subsidised psychology sessions. But the current federal government says it has no plans to do that. Health Minister Mark Butler has said there's a shortage of psychologists, and so increasing the number of sessions would only create a bottleneck. Here's one possible solution. Jacinta and MJ say some patients could benefit mentally and emotionally from other services too, not just psychologists. For example, MJ has seen a speech therapist for gender-affirming speech therapy, which can help with feminising or masculinising your voice.
Give a lot of trans people easier access to that. Then the mental health care problem isn't quite as drastic because, you know, you're not struggling with dysphoria to the same extent.
Another example from Jacinta, mental health occupational therapists.
I will stand by my mental health OT until the day I die. With the OT, it's more practical in like a day-to-day sense where it's not just coming in and talking about this is how I'm feeling and trying to unpack that. It's more...
MJ says even exercise physiologists can support mental health.
I didn't know what it was. And it was life-changing for me to go to that just for like 1 or 2 sessions.
Mental health OTs, speech pathologists and exercise physiologists can be subsidised by Medicare. For example, under a chronic health management plan, that's the one that subsidises up to 5 sessions with an allied healthcare provider. But that's just not enough for a lot of people with chronic health conditions. And once you've run out of Medicare rebates, these sessions often cost up to a couple of $100s an hour.
It's something that was such a game changer for me. But yeah, again, the cost for that, it was never something that I could have done without the NDIS funding.
We could also get creative with the kinds of therapies that could be subsidised under Medicare to support mental health, MJ says.
What I would really like to see is more support institutionally for things that help mental health, but are not currently kind of covered. But I think if you had an integrated view to mental health in terms of art therapy, music therapy, dance therapy, exercise physiotherapy, socialization, there's data in the world right now that really shows that just prescribing people to go to arts events is significantly beneficial for their well-being. If you actually wanted to relieve people's mental strain, bring in more ways to take care of people and take advantage of the considerable resources that are just sort of lying on the sidelines there.
What else could help unwell women better access suitable mental health care? Well, researchers from the Liptember Foundation and the Centre for Sex and Gender Equity in Health and Medicine, which is founded by the George Institute, have a few suggestions. They include integrating mental health into women's general health services. So, in practice, that would mean providing more gender-targeted psychological support within health services such as endometriosis clinics. And beyond that, the researchers say the government needs to look at building mental health considerations into all new policies and services created for women's sexual and reproductive health. So we've looked at a few actionable ways we could improve mental health care access for unwell women and gender diverse people. But of course, addressing the mental health toll of medical misogyny is just one piece of a much larger puzzle. And tackling that larger picture will need to be multifaceted. It will take a massive effort. There is some change on the horizon, fueled by federal investment in women's health and growing momentum from advocacy groups. But there's still so much room for improvement.
We have enough women speaking out about being misdiagnosed and suffering for years. That's enough. Enough is enough, really. We can't keep talking about it. We need action.
Over the last 5 episodes, we've touched on some of the other foundational stuff that needs to change. Here are the biggies, the top priorities we've covered throughout this season of Beyond Hysterical. Number 1, we need a medical research shake-up.
That's something really simple that could change very quickly and easily. There's a century of research to catch up on.
Government funders, researchers and medical bodies that set clinical guidelines all have a part to play here, and so do pharmaceutical companies.
They need to be properly integrating sex and gender into their trials.
Number 2, we need to train doctors about women's health and women's pain.
How people experience pain differently, how they respond to different treatments. That's not necessarily properly reflected in how we train our doctors.
Because it's time for medical science to stop treating male bodies and male health as the default. Medical training is urgently overdue for an overhaul. We need to teach doctors to flip the script so that if they can't find a diagnosis for a woman's symptoms, they don't see that as a sign she's hysterical or making it up, but instead as a sign that maybe there's a gap in the research or the doctor's own knowledge.
In the field of medical science or research, and women's health often is thought about as a niche area, but in fact it shouldn't be.
We also crucially need widespread doctor training on trans and gender diverse sensitive healthcare, and training to address systemic racial bias.
There needs to be a really big focus on cultural safety in healthcare.
Number 3, governments need to help by funding so much more. Because even though the federal government has recently been investing in women's health, the experts I've spoke to throughout this series have raised so many areas that still need targeted funding. We need funding into women's health conditions, funding to cover doctor training, funding of women's out-of-pocket healthcare costs, including through reforms to Medicare, funding for maternity care reforms, to increase trauma-informed healthcare, and to give women better access to continuity of care throughout their pregnancies and postpartum. We need funding of more public clinics, including multidisciplinary clinics, so everyone can get the care they need without paying hundreds or waiting too long or bouncing between specialists who don't always talk to each other. And we need funding for GPs to better manage women's complex chronic healthcare needs.
So I think better funding GPs is a really good idea, giving them time and resources to coordinate complex care. A lot of GPs are under the pump and they're expected to manage everything in 10-minute appointments, which is really not sustainable.
We've seen the start of some change in this space. And the response from women when politicians actually hear them shows how necessary this investment is. Labor politician Kat Theophanous, who represents the seat of Northcote in Victoria, puts it this way.
The response from the community has been extraordinary. For so long, women's health has been under-researched, underfunded and overlooked. But women have been speaking up, and now finally they're being heard. There's a real sense of hope and relief across the community, and an even stronger sense of determination that this is only the beginning. For the first time in generations, women are seeing change that reflects their reality.
Number 4, medicine needs to better support women doctors, so we have more women leaders tackling medical misogyny from the inside.
I think progressively women just drop out because it's just too hard, or they have to make that very difficult decision of, do I prioritise my career or having children?
Number 5, all of this will only change as part of a broader societal shift. A move towards hearing women's voices and taking them seriously.
Doctors are still being trained in a society that doesn't value women's voices. And so that's not something that can be solved by universities or public teaching hospitals alone.
And really stamping out medical misogyny will mean amplifying the voices of the most marginalised women, those whose voices are dismissed the most.
I think the other part about how people are perceived and people not wanting to be pushing is a much bigger issue around women's voices in the world. And it's very difficult to just say, well, just speak up. And I'm really conscious. I'm sitting here as a middle-aged, middle-class, educated white woman, and I find it hard sometimes. So imagine if I was an Aboriginal woman who'd experienced systemic abuse and racism. If English was my second language, if I didn't have any education, if I had cultural barriers about questioning someone who's older than me or someone in a position of authority, I think it's really important that we keep that in mind as well.
It's time to stop dismissing women and start hearing them.
I guess at the day-to-day level, it's all about listening to women and believing them when they describe their pain, and allowing the system to give them time and respect and proper access to care.
Because so many of us who have lived through medical misogyny have told our stories, shared advice, offered solutions and highlighted priorities. Now it's over to governments, medical bodies and healthcare professionals. The ball's in their court. And it's time for them to listen to women and leave hysteria in the past. Thanks for joining me on Beyond Hysterical's final full-length episode. And thanks to my guests today, Siona Ilalior, MJ O'Neill, Jacinta Dietrich and Erin, among others. Beyond Hysterical is created and hosted by me, Grace Jennings-Edquist. I'm also the executive producer. Sally Spicer is our senior producer, and Michael Joyner is our audio editor. Don't forget to follow the show on Instagram at Beyond Hysterical. Beyond Hysterical shares the opinions of individuals and provides information for educational purposes only. It should not be relied upon for health or medical advice and is not a substitute for professional health advice.
They told us, sweetheart, it's all in your head. Just a womb on the move, the man once said. Time moved on, but a shadow remained. Our pain ignored, she's emotional again. Brushed off, blamed, in creeps self-doubt. Still told to breathe instead of shout. Girl, the system wasn't built for us. But for men, why you making a fuss? Enough. If listening to women is seen as radical, then come on, let's move on from hysterical.